My name is Dr. ISEKO. I'm an interventional cardiologist with CardioCare Hospital. What that means is that I use needles and then pass things to the heart, and we try and fix blocked vessels and put pacemakers and stuff. That's really what I do most of the time. Otherwise, I work in Limi Hospital. Today, I'll be walking you through basic life support, what to do when somebody collapses. We'll take it in batches and we'll take it systematically. Normally, this is a full day course on only basic life support. But we have a methodology which we have used over the years that allows us to be able to get this done in a short time. Granted, this class size is a lot bigger than I expected, but it shows that there's hunger for education, A, and people are trying to japa, B, one of the two. Either way, before you japa, you go learn. If your visa fail, you go there, you go learn. All right. So, sorry, can we have one house? Just focus and listen. Because the time is short, you need to focus. Please put social media away. If you were sleeping, just wake up now, shine your eyes, carry your notebook and write. Okay, that's very important. Will it play? So this is for illustration purposes. This is a video. This video virtually almost made me cry watching it. All right. This is a football match. Referee just gave him a yellow card.
Hello.
You can see them pressing. Can you see that? They are trying not to show, but if you watch carefully, you will see them press. You can see how he fell down. It looks like he's breathing. Then you can see them turning his head. Can you see people turning head, putting hand inside mouth, don't putting spoon, right? Before the people now run, 6, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. So we know that at least it took 30 to 40 seconds, maybe 1 minute before proper CPR started. So that is it over and over again. He was 27 years old. He did not make it. Yeah. He died on the field and that was it. Active footballer. All right, so what may have been done better? What may have been done better? If this happened again, if this happened here, God forbid, will this person survive? If it happened in your church, in your mosque, will that person survive? If it happened in your home during Christmas celebration, will that person survive? So this is why we are here. This is why we are here. We know that every 10% of improvement in standards leads to a 30% improvement in return of spontaneous circulation, ROSC. So even we that know it, every time we have to learn it, we have to relearn it and relearn it. That small extra difference or practice improves the chances of the person. I did a case about 2 months ago. Person had had an MI, we put in a stent, very routine. That was the most simple and innocuous procedure. In fact, maybe the person that was learning with me, I would say, okay, go ahead and do this case. As soon as we just said the stent, everything, before we know it, bam. You know, and chaos after chaos after chaos. The man is alive today, don't get me wrong. But without these small knowledges, rehearsed, relent, unlearned, that person may not survive. And this happens in our wards every day. About maybe 9 years ago, they called me to the labor room. The woman was about to deliver, and then boom, cardiac arrest. And then the surgeons were now trying to get the baby out. Either she had an amniotic fluid embolism or something like that. Okay? So, it happens everywhere. Some years ago, they called me to a beauty spa or salon or whatever. All these places around town that are putting things for people. Right? And patient is not breathing, Before they will get me, yeah, that's died. Nobody could do a proper CPR, including the doctor that they called there initially that was doing something in that office. So this information is not information for a certain group of people. It's information for you. It's information for me. It's information that we should know. And as you can see in that video, if you take the actual time, it may have taken almost a minute plus before they started CPR. A lot of people will do what they did. Turn the patient to one side, put spoon in the mouth, including people in this hall. Put spoon in the mouth, no, let the mouth close. The last man that died in National Assembly, that's what was happening. The man said, I needed water. Then somebody said, no, give him water. No, pour water on his head. Get him Coke. Have we not seen them? Even the one that was acting, you remember the one that was acting when they say, where's the money? You remember? People put mouth inside and put hand like this. Now, it is funny now, but think about it. If that man was having a real cardiac arrest, there was nobody in that room that had the common sense of what exactly to do. This is what we are living in. We can sit down and point our fingers at leaders anyhow. But if you are working in a hospital, you are taking care of patients, and you don't know what exactly to do. If you are operating and this happens, if you are in the labor room, emergency room, and this happens, you are part of the problem. It's not trying to run to another person's country where they have made it by force. It is by you doing it here. Good. So that video is and there are many videos like that. It's another video. That one virtually made all of us cry when I watched it in Nairobi. That was Sam Okparaji was one of them. And when they did this time, the guy put a timer on it. It took 3 minutes to start CPR. No, he's faking it. No, because when sometimes some people have a cardiac arrest, it looks like a seizure because of their hypoxia, no blood to the brain. So he did like this. People were putting hand in the mouth. They brought water. I don't even think there was an AED in the entire sports auditorium. So before they started active CPR was 3 minutes. If you watch that video, if you see the way the woman was doing CPR for the short clip, I don't know how you saw it. And stop. That was inappropriate CPR. I'm not saying that's what killed him, but that was wrong CPR. Several years later, it happened in one of the matches, and Mourinho made a whole show, those of us that watch matches. And because of that, all the stadiums in England had to put a direct route for an ambulance into the field of play. And then we know during the Euros, right? Christian Eriksen, who now collapsed, and the same time, but he was resuscitated. In that case, when they put the timer, the CPR started in 9 seconds or 8 seconds. The people were out, somebody jumped in, and pam, and that was now proper CPR. So all of these things we are saying is not just rubbing somebody's chest or doing whatsoever. It literally saves lives, and is successful. Another thing we have seen is people run to the patient side and carry torchlights and say, wait, let's look at the eye. Dilated pupils. Sorry. Has that happened to you? Just keep on laughing, don't talk so that we don't know you are the one. Yes, these are all things that people do. These are all things that people do. In fact, sometimes there are people that were brought in dead that you do CPR. One in maybe 100 will revive. So even in our facility, even when they do BID, quote and unquote, so far it's not called stiff BID, we still try something. Because 1 in 100 of them, you'll be shocked. You will just put, you will see CV fib, you will see shock. These are the real things that are at play here. So we're not here by mistake. We're not here. Some people just came here to while they wait time to get away from work. But really, you should be able to put together chest compression, ventilation, proper use of a defibrillator. Okay? Please, I want to know when you are ready, and I need a defibrillator on stage. Okay. So basic life support. I think I've scared you enough, right? Yes. Yes. But that happened in Europe. The good thing about it is that they are improving. We are still praying. Nothing wrong with prayer, but we must make sure that we match that with requisite knowledge. So, basic life support refers to care people provide to patients when they are experiencing a respiratory arrest, a cardiac arrest, or airway obstruction. It involves all the psychomotor skills that are needed for CPR, AED, and obstructed airway for all patients. I want us to differentiate two things: respiratory arrest versus cardiac arrest. Like we said, you will get all the slides and you will have access to our YouTube page. We have a YouTube page. We have lots of these already there for you to learn in good language. Thank you very much. And then you can have access to the videos again and again. Thank you. So, what is respiratory arrest? In respiratory arrest, the patient still has a pulse. However, the patient is not breathing well. This is the proverbial gasping sometimes. The patient is doing like this. And then we'll say, no, it never reach. Then these are people will be watching. Does that happen in your facility? No, it doesn't happen in your facility. Well, I can tell you that when I was house officer, we did it. And yes, I'm confessing my sins. Because later when we got to know, when I said, we should have intervened. But when the patient starts gasping, you just say, no, he's still breathing, he's still breathing. Then you'll be waiting. Then when the patient stops breathing, then you now run to start. No. That already is considered a respiratory arrest. So anytime somebody has agonal breathing or not effective breathing, they are considered to be in respiratory arrest and they need to start having some therapy. Mr. Samuel, we need to have one instructor per mannequin. One instructor per mannequin. So if we don't have an instructor for the mannequin, take the mannequin away so that we will now manage the rest, and then we'll now go batch by batch. So however, in cardiac arrest, there is no pulse, there is no breathing, and the patient is unresponsive. Can we say it together? No pulse, no breathing, unresponsive. This is important. You know why I say this? Even in myself, I say these things over and over again. Because when it's happening, this is what has to come to your head. And it has to be at spinal level. I don't know what people know what spinal level is. It cannot be from your head. You cannot be thinking, is this cardiac arrest? It has to be like reflex. Like when you touch fire, you don't think, this is fire. You get it's at spinal level. Like you touch fire, you just pull back. That is how this thing has to go. And some of the time when I tell you to repeat something, it's just to try and move it from your head to your spine. So that next time you see it, you will not be looking for a spoon. Okay, so anytime the electrical and mechanical system stops, there is complete cessation of the heart's activity. More often than not, when the heart stops, everything stops. When the respiration stops, the heart will still be beating. That's why we have respiratory arrest, right? While when the heart stops, everything typically has stopped. So, I want to differentiate these three things. Even among some level of healthcare professionals, there is some problem defining and differentiating these three. Number one, heart failure. Number two, heart attack. Number three, cardiac arrest. I know this is too low for some people, sorry, but please indulge me. Heart failure, just think about heart failure like a pump problem. It is not pumping enough blood for the body, and typically it's happening over a period of time. Okay? May eventually lead to a cardiac arrest. In heart attack, it's a pipe problem. The pipes supplying parts of the heart are blocked. I want to show you one or two cases that I did, and then the blood flow to the muscle is blocked or severely reduced. So this may lead to either heart failure or it may lead to cardiac arrest immediately. So the patient typically, the problem is heart attack, and tomorrow Dr. Adefila will take us on chest pain. What to do when somebody has chest pain, because this sudden cardiac death we are talking about may have started as a heart attack. And he didn't make it. The question I ask is, at 1 a.m., likely this man had a referral much longer. For him to know exactly where it was, we're not so where at the behind, you know how it can be behind. For him to have it and come at 1 a.m. And as he was landing, another car was coming behind him, a friend who he had called, and the man did not make it. So by the time the man was having chest pain or what he called ulcer pain, because a lot of times we say ulcer and actually heart attack, nothing was done immediately, and before we knew it, it led to cardiac arrest. Now in cardiac arrest, the electricity stops. As the electricity stops, the fan stops moving. As the fan stops moving, everything stops working. So that is cardiac arrest. It's a sudden activity, immediate, and if nothing is done, it is death. Final pathway. May lead to death eventually, can lead to death within shortly, and leads to death in sin. No. All right. Is that clear? Do I need to go over it again? It's very clear, Abi. Beautiful. So, how do we institute basic life support, especially as it relates to hospital? We have this chain of survival, which was devised by different people, but mainly I think the American Heart Association. And this chain of survival is not just somebody's idea that people just came up with. It comes up and everything we're doing. So while we are looking back at that person that died on the football field, knowledge has changed dramatically over that time period. Dramatically. Meaning people have done studies upon studies. Can you imagine after a cardiac arrest, people take all the data. How many times did you do? What did you do? And find who survived more. So that we can now improve it. So we now have this chain of survival. The adult in hospital cardiac arrest and the adult out of hospital cardiac, that's what OHCA and IHCA means. In hospital means, first of all, you need to early recognize and prevent it. Then once prevent before it happens, you know the people that are more likely to happen. Then early recognition. So for the case I was talking about that I did, I had a heart attack yesterday evening. As I was doing it, we knew this is a high-risk patient. Defibrillator already on. Do you understand? Crash cart ready. Adrenaline, atropine, amiodarone ready. While we put the stent and open up the blockages, he had SVT, which we'll talk about tomorrow. As it went on, IV amiodarone in, because you are ready. So you have to recognize those that are at risk and be ready. You almost do not start walking when you come to work without going around to make sure you are ready. You don't start. Do not take a labor delivery without making sure that your hospital is ready. So as you go here, leave this place, you go to your ACS certificate and go to your medical director and say, medical director, I now have ACS. We need this in this place, otherwise we cannot take any delivery or do any theater. When they sack you, I'll tell you sorry. But I'm sure you understand what I'm trying to say. You can say it in a diplomatic way to say, what we learned, we did some things. I mean, hope you understand what I'm trying to say. So, in hospital, recognize, activate an emergency response. What does this mean? You must have developed a system of response before it happens. So I'll tell you a trick of what we do. This is an in-house secret. Hope there are not people listening too much. In-house secret we use in CardioCare. Every quarter or thereabout, everybody does a drill on BLS. Where is this? Where is that? Where is this? I'm talking from cleaners to security men to, because sometimes you can be doing CPR for 2 hours or 1.5 hours, and 2 of you cannot do it. You need everybody. So everybody must learn. Receptionist, everybody. Okay? So we all learn, we practice it. You must practice, otherwise, if it is when the person goes under that you start looking for oxygen, that you find out that the ambu bag is in matron's office, is locked. Abi? It's so. That is when you find out that there's no ECG electrode. And God forbid, it's somebody related to you. What will you do then? You are the one that has failed. Okay? So, you have to have an emergency response, a system to activate that you call for help, and a certain number of people must come in that are ready to do pre-specified activities, preferably pre-rehearsed. Do you get it? A certain group of people, pre-registered or prepared, with a specified group of activities, and preferably rehearsed. So once I get to the room, and I will talk about that when we go on ACLS, because ACLS is a little bit deeper. We'll talk about team coordination. I typically go to the foot of the bed. Then I begin to organize. Person recording moves. People doing CPR move. People for airway move. People for drugs move. That has to be pre-rehearsed. So when you see patients coming back, they came back, they're now alive. Wow, thank God. Let's start moving to the next thing. It's not because of this. It must be prepared. So that emergency response must happen. Then high quality CPR, defibrillation, post-cardiac arrest care, and recovery. If it's out of hospital, we don't have emergency response in Nigeria, minister is not here. But I know that they have started something. I know it has not worked out yet. I was part of a technical committee during the last ministry to try and set up something, but different things. One day to come up. But high quality CPR, defibrillation, resuscitation, which should happen while you are en route to the hospital. So we normally advise in Nigeria that don't start moving the patient until you get a vehicle capable of you continuing your CPR while you are moving. Very important. And these are all the things we teach them in the heart failure support group. Because we don't want the patient, they say patient slump, they start running from Lugbe or from Jikoi and say they are going to CardioCare. The patient will not make it. They did not do anything. So this is what you should be doing. This is how you should do it. This is kind of support you are looking for. And the patient's relatives will learn that so that they can do certain things. Get the patient to the hospital alive. We can take over and do what is necessary. All right. So then resuscitation, post-cardiac arrest care, and that. For pediatrics, prevention, CPR, emergency medical services, and advanced life support and post-CPR. I will not talk so much. Next year, we are mulling our second pediatric symposium, so we'll focus on pediatrics. We have summarized BLS as per CardioCare in 5 C's. In 5 C's. In 5 C's. Number 1, check for safety. First and foremost, check for safety. It has happened, the patient has collapsed, it's in front of you, we are checking. Is there any exposed wire? Is oxygen open? Is there a threatening relative? That is part of safety. Relative are wondering if this patient should die. As you are doing, you start looking for way out. Abi? You check for safety. Number 2, you confirm the arrest. And we said that the arrest has 3 components. Non-responsive, no pulse, no breathing. Remember, Abi? Non-responsive, no pulse, no breathing. It has happened to me. By God's grace, a lot of them have come back. But not everybody comes back. Okay, what's happening? What's happening here? Pam, monitor next. Start CPR. And then everybody knows what to do. Okay, very, very critical. So, if you do that, if you find out that there is normal pulse and the breathing is normal, maybe they're just not unresponsive, maybe they've had a stroke like Dr. Mimi said, monitor till help arrives. You call for help. If, however, the pulse is felt, but the breathing is not normal, you begin rescue breaths. That is, you begin, we'll show you that with the ambu bag. I need the ambu bag, I need a mannequin up here. And I need a table up here. All right, so I hope this place is... yeah, so if the pulse is felt, but there's no normal breathing, now you just be giving breaths. Connect your oxygen and you be giving breaths. However, no breathing, no pulse, he's not responding, then you know you have a cardiac arrest. You are calling for help, and by help, we don't mean, we don't need that one. we don't mean, hey, we don't mean that one. What we mean by help is people. People that know what to do. So you call a code. If you have a code blue system in your hospital, you call for help. So once you hear help, help, everybody knows what that means. Move immediately. Crash cart is coming across. Oxygen wires are coming across. Monitors are coming. Defibrillators are coming. That's what help means. So help means people that are trained. Help also means an AED. And then we start CPR immediately. So the final C is you start, the CPR comes, the AED comes, advanced cardiac life support should also start. The preparation for advanced cardiac life support should also start concurrently. So this is essentially a summary of what it is supposed. So now I will go into details. Are there any questions so far? Is it straightforward? Is it confusing? No. Great. If you have any questions, please just put up your hand. This time I don't mind stopping. Please. This is life and death. If you want to peace, just hold it small. All right, so in the hospital, identify patients at risk. Close monitoring of patients at risk. So you could have alarm signs. Can you come up here or to be there? Which one is this here? We have cameras. Don't worry, if it's here, it will see you. Put it down. Let's not test the stage. All right, so you have patients that are already at risk. You begin close monitoring. So in every hospital, we advise that you have what we call alarm signs in CardioCare. What we call alarm signs. There are certain things that when a nurse recognizes, they should trigger high level of monitoring. For example, a low blood pressure, 90/60 and below. A drop in blood pressure, more than 20/10. Blood pressure was 140/90, 140/90, now it came to 110/70. You don't wait for anything. A change in breathing, alarm sign. Some new bleeding, alarm sign. A massive rise in bleeding, alarm sign. So once you notice those ones, patients with any of the organ failures, alarm sign, you already know that those patients are at high risk, and you now begin to make arrangements. Those are the patients that we typically like to move to the ICU, except the other issues. And even if you cannot move to the ICU, what did I say is the poor man's ICU? One nurse, one doctor, one patient. They sit down there. If they want to go and pee, somebody should come and exchange for them. They continue. You have good monitoring, and you have automated drug delivery systems. Very important. All right. So ensure everything is ready for that patient. Like I told you about the patient yesterday, what did I do before we started the case? Make sure that everything was ready. Anything that happens, we are ready. And nothing happened, patient is doing fine. All right, so safety first. Check for safety. Pool of water. Open wires. One of my very good friends in ophthalmology that time, he saw somebody in cardiac arrest. He was driving, people were gathering. He parked his car in the process of crossing the road to go and help. Pam. And that was it. So you may need relatives to be away for several reasons. One, they may be disruptive, shouting, threatening. Two, they could cause unnecessary panic, both in you and them. And three, they could be taking unnecessary videos. Okay? In this video age, you should be very careful. You should be very careful about that. So the next thing is check for responsiveness. Check for responsiveness. Okay? So we check for responsiveness. How do we check for responsiveness? Now I will come down. And cameramen, I will need your help. Close up and far away. Leave that there now. Get the adults. Get the adult one. This is killing them. All right. I'm sure you can see somewhere there. Good. So how do we check? Mr. D Bambambiekun. Mr. D Bambambiekun. Okay, so that is how we check, Abby. We check vigorously, tapping it for the patient's name. So number one, check for responsive. Remember we said unresponsive. What? Number two, no pulse. Number three, no breathing. Thank you very much. So, where's the remaining now? What happened to my slide? Okay, fine. It's not there on the slide. So, unresponsiveness. Next thing, check for pulse, right? How do you check for pulse? You scroll down, I say scroll. Get to the trachea, slide your fingers down, I'm still okay for now. Slide your fingers, just hang around. Slide your fingers to the side of the trachea. You will feel the carotid pulse there. Can you do that with your neighbor if they allow you? So, if you cannot feel the pulse now, it's a problem. Because the person around you is definitely alive. Please, I'm not joking. Do it now. Don't imagine. Do it. Do it. Do it. Nothing will happen. Please, sir, do. If you don't feel it now, when you are looking for when it's not there, you definitely will not feel it. If you are not looking for it under tension, you definitely will not feel it. And worse off, if you are emotionally connected to that person, you definitely will not feel it. So this is the time to get used to checking for it. Cameraman people, check. Check pulse. So trachea, go to one side or the other. Don't do both sides at the same time. Only one side at a time. If you do both sides, the person will go unconscious in front of you. Go to one side. Can you feel it? If you cannot feel it, raise up your hand so that somebody will help you. We have consultants around. If you cannot feel it, just raise up your hand and somebody will help you. You must feel it now. It's very important. Don't do for yourself. You cannot help yourself. Do for somebody else. Do for somebody else. Can you feel it, Tinabi? Yeah, but you're standing now, so you're alive. Do for somebody else. Please and please. Okay, good. Again, I don't know if somebody can zoom in here. If you can zoom in here. Who is the one zooming in? Okay, fine. Just see the trachea here in the midline. Once you go down, especially at the level of the Adam's apple, once you go to the side, one finger break to the side, and you press with your two fingers, you should be able to feel a pulsation going boom, boom, boom. If you have atrial fibrillation, it will be sound like gong gong, go 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 go, bang 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 bang. You should stop by immediately before going home. All right, so is that clear? Beautiful. So we've checked for pulse. The next thing we want to check for is breathing. And how do we check for breathing? We put our ear to the mouth and we take our eyes to the tummy. So like this. But typically, like I said, once you don't feel a pulse, chances are you're already dealing with cardiac arrest. So you take your ear to the chest, to the ear, and see where your eye is looking straight here at the belly button to see whether it is moving. Now, you have exactly less than 5 seconds to do this. 5 seconds to do this. That is why I started timing for you, to show you how long it took for that person to get CPR. Okay, that's problem number one. So, most of the cases that will survive a cardiac arrest are those that somebody witnessed it and the person was able to institute appropriate care after witnessing. Okay, so when the person witnessed, it's like, so this is how you do it in 5 seconds. You check the respiration and the pulse at the same time. You can see my ear is by the mouth, my hand is on the neck, and my eye is on the tummy. So like this. As soon as I've done that, I have determined this person. I've already shouted, Mr. Adibamambeku. Right? We have discovered now. The next thing now we do, slide please, hello, slide please. The next thing now we do is call for help. Please, don't leave the patient alone. Don't leave the patient alone. Remember, it takes about 1 minute for it to be all over. And after like 1.5 minutes or 2 minutes, there's likely some irreversible brain damage of no blood flow to the brain. And after about 3 minutes, it's all over, of nothing. It's forever all over. Do you understand? So you want to start CPR as quickly, as fast as possible. In cases where I've had to do it, because somehow now I've become a surgeon, like my prof, I am doing a case, and the thing is happening as happens. It does not matter sterility at that time. Boom! you jump in. Now we'll talk about advanced ways of doing that tomorrow, and I will show you how to use a temporary pacer, hopefully. Okay, fine. So more people to assist, senior people to assist. Sometimes that senior person assistant may be on the phone while the person is coming. Okay, sir, what about this? Oh yeah, do this. Oh yeah, do this. What about this? Check this. Have you done that? So that could be help. Just put it on speaker and you can have really good assistance via phone, thankful to technology. AED gets you prepared, prepare for ACLS, and then continue CPR while help comes. So code blue, consultant, emergency ACS. There's a patient that had heart failure. We wanted to put CRT, she was too sick, developed a cardiac arrest. I think Dr. Adefula will remember the patient. As they called me that they are doing CPR, and the patient just suddenly just came, the patient either they just took a drug or whatever, and just did like this. As they called me that she's not breathing again, I just jumped into my car. I just woken up. I just jumped into my car. I got to the hospital in maybe 7 minutes. They were still doing like that. What are you guys doing? You need to escalate this therapy. What? Move. This is how we now escalated up. She came back. She came back. So that call for help is very important. Somebody is likely seeing something you are not seeing. We shocked her once, I think, and she came back, gave the IV drugs, and then she came back. She didn't make it eventually, but at least for that time she came back. Enough time for the rest of the family to come in, and that can be very important. Okay, so if the heart is bad, the heart is bad. It's only so much you can do. All right, so ACLS trolley, invite skill teams. Now we'll give you a list, or we'll show you the list of things that must be in your crash cart. That will be tomorrow. This was what I was talking about. Sorry, it came after initial breathing. And you can see how I told you. Ear to the mouth, eye to the tummy. Check for movement of the chest wall. This is how we check for the pulse. You check the parotid pulse at the side of the neck. So slide your finger into that groove, just between the trachea and the neck muscles. Please don't do it for yourself and don't do two sides at the same time. If you do two sides at the same time, you are obstructing all the blood flow to the entire brain. Do you understand? So if the patient was alive, that is the basis of sleeper hold in wrestling, where you hold somebody from the back and the person just collapses. What just happens is that you are blocking both blood supply to the brain, and the person will naturally faint off. Okay, so you have 5 seconds to do it. You can see how I was demonstrating. You have exactly 5 seconds, but not more than 10 seconds. You must start immediately. 5 to 10 seconds. 1, 2, 3, 4, 5. CPR has started. Hello? Those at the back, are you with me? CPR has started. I'm told that there was a church in town. During praise worship, the person was playing drum. He had a cardiac arrest. He died though. Because people were still, everything. This kind of people would turn to the side. Different things. He didn't make it. 5 to 10 seconds you have to check and start immediately. All right, so I've told you about this. Respiratory arrest, agonal breathing is the same. Agonal breathing is what we call gasping. How many people have seen that before? Everybody, right? Did you start resuscitation immediately? Did you start? Somebody shaking head? No. Did anybody start? Anybody that started? Nobody. So only one person in this whole hall. So you see why we are doing the ACS. You see why we are doing the ACS? Very, very important. So, very important. Now, in cardiac arrest, there's no, this that we talked about. The vast majority of people that survive are those that the cardiac arrest was seen, and those that had immediate chest compression and defibrillator. The American Heart Association has what they call hands-only CPR. That even if you cannot do mouth-to-mouth outside hospital, you should start compressions. That is sometimes is almost as effective as whether you do ventilation or not. So if you cannot do anything, at least start effective compressions. Very important. I have seen it work times without number. The moment I learned proper BLS and ACLS, I was like, Jesus, all the people that died. Ha! Do you understand? When you finally learn it, then when you do it and it works, those CardioCare, how many people have seen it come to life, Abi? Plenty. It's like what has been happening all along. Fine. So high quality CPR is typically associated with good outcomes, adequate compressions, minimal interruptions. Okay? And AED. Now, when you want to do the compression, very important. No, I need your help. Very important. The reason we don't have home mattresses in hospital is because of CPR. The reason you don't have home beds in hospital is because of CPR. Because those beds will be too low for you to give an effective CPR. That is why you must have standard beds. If you notice, most modern hospitals have removed every bed that has spring. I don't know if you have noticed that. That every modern hospital, some people are still buying those second-hand ones with springs all around and say it's comfortable. It's not correct. Now, if you have a thick mattress or a soft mattress, most, do we have our board? Most of the crash carts that you buy have a board. And if you don't have one, just call your carpenter, Katapo, see wood like this, they should cut. Just keep it somewhere near your nursing station. You slide that board under the patient so that you cannot have a firm surface to compress under. So if you have a good theater bed, you will see that it's already made firm because of that. If you have a good hospital bed, it is not very thick. If the patient was on an air mattress, typically an old patient that has been very ill for a while, you have to take it out or flatten it immediately. If you have a standard ICU bed, there's a button there called CPR. You will press that button, it will flatten the bed immediately, and then you can easily put your board under. So you typically have that board. If you don't have a board, just get a thick piece of wood, like this one on this table, have somebody cut it and keep it. Slide under the patient. That is the first thing, so that you have good quality CPR. If you are not too tall, you may need to get a stool so that you are above. This one will likely happen for patients at home or out of hospital. However, if you have a spring bed, I've seen go to some hospitals nowadays and they have this nice hospital beds that look like hotel rooms. That is not hospital though. That is a death trap. Okay, very fine and beautiful. It's not correct. If that happens, however, and you just have to do it, what do you do next? Grab the patient. Move the patient to where? Floor. And then you start this one. But the problem with the floor is that how do you get oxygen, drugs, everybody, airway? You can see where the problems now lie. That is why you must still stick to what is standard. So, backboard, deflated air mattress, hand in the middle of the chest. So just under the xiphisternum. The xiphisternum, where my camera people? Guy, no sleep now. The xiphisternum is this place right here, or under the chest. This place here, just here, right? That is the xiphisternum. So you just want to be directly above there, right between the two breasts, okay? Right in the center there. That's where you want to be. You want to take your dominant hand. If you are right-handed, that is your right hand. If you are left-handed, that is your left hand. And place that on that area. Then you take your non-dominant hand. For me, I'm right-handed, so my right hand is coming here. Then you take your left hand, your non-dominant hand, and then you lock it in. You want your heel to be on the center of the chest of the patient, like this. And this is locked in. Having done that, what is the next thing you need to check for? Your elbows. Your elbows cannot be like this. You want it straight. You want to imagine that there's no joint here. So when I come in for, they call for a CPR or a code, and I come in, there's some people that say, get out from there, get out from that place. After I finish, I can tell them sorry if I remember. But otherwise, get out from there, get out. What are you doing? You're doing like this, massaging the patient. Do you get it? So you want high quality CPR. Elbows locked, dominant hand center of the chest, non-dominant hand here locked in, able to do the, not your palm on the chest, the heel of your hand. Heel of your hand. Where's cameraman? Cameraman, don't sleep. Oh. Heel of your hand, the heel of your hand, not your palm, not your fingers. In a good CPR, what will happen if they do autopsy? They will see some small fractures. In a good quality CPR, they might likely see some small fractures. So the hand like that, and then you start. This is this thing. Now, very important. You see the elbow, the shoulder. The shoulder should be almost 90 degrees to the body. So you don't want to do CPR like this. Can you see me? This is not correct. Like this. This is at an angle. You want to do CPR where you are like this. So you see, if the bed is already this high, what do I have to do? I am standing on my toes to be able to do it. So now my shoulder is now a little bit straight with it. Otherwise, immediately my team know what to do. A stool will just come in, or whoever is there will lower the bed. If the bed can be lowered, the bed cannot be lowered, a stool comes in so that you can go up immediately and then you can start. The people that are shorter already have their stools somewhere. All right, and then we start our CPR. So we want to have a depth of about 5 centimeters. 5 centimeters is about 3 of your fingers, 2 to 3 of your fingers. So 2 to 3, right? Those of you that did ONG, yeah, I've been checking this one. This is 4 centimeters. I've been ONG. I can't remember. Sounds like that. So 5 is between 2 and 3. So this is the depth you want to push in. You want to push in almost three fingers in. Okay? So you want to push that in, and then you must allow the chest to come back. So what I have seen, sometimes people doing CPR, they are doing like this. They don't allow they are going too fast. They're not allowing the chest to come back. By the time it goes down, before their hand comes up completely, they press again. Again, if you press and continue pressing like this, what's happening? You have compressed the heart completely. You've not allowed any blood to come in, and you are the one that will kill the patient. Do you understand? I hope you can see it. It's clear, Abi. So you pressed, you not let to come back. You continue pressing like this. You have compressed that heartbeat, but you want it to come up. So when you press, you want it to come back up. Press, you want to come back your hand up. So when we press in, we come back, allow it to recoil completely before we press again. Now we want to do the... What happened? It went back or something. Now we want to do it at the rate of 100 to 120 per minute. I used to have a slide here with a study that showed the effectiveness of those that came back and those that did not come back. So somebody actually did a full study measuring every time they did CPR, and showed that the people that survive the most are those that survive between 100 and 120. Above 140, it starts getting worse. Less than 60, they almost do not get back. So that kind of one that just pressing, or like that video that we watched, person did like this, then stopped, then they stopped. I can imagine so many things were going through their mind, all the cameras, everybody shouts, everybody crying, different people, all kinds of things. All right, we know better. So we can now see 100 to 120. Now after 30 compressions, we follow by 2 ventilations until we get an advanced airway. Is that clear so far? Is there any question? It's very easy, isn't it? Now, until you try. When you try, then you see that it's not easy. Some of you, I will laugh at you. I'm joking, don't be afraid. All right, so shoulders over the hands. So you try and compress. So you can do, there are different types, there are fulcrum techniques, but I will not stress you with all of this. So lock your elbows, minimize interruption. What do I mean by interruption? Somebody says, okay, Let us take the patient to the hospital now. Let us transfer the patient, Jare. Let the patient not die in our hospital. Let them not say die in our hospital, Abi. And they now stop. They now carry the patient to a stretcher. They now move the patient on the stretcher. Then they reach. The lift did not work. Then they press. Everybody lift. Then the lift comes up, opens door. Then they enter the lift. Then the NEPA took light. Then they wait for the generator. The generator came back. Does that happen? So all of that is interruption. Or sometimes somebody just says, wait, are you sure? Let me check. Then you now stop. Kai, it's like something is here. Okay, all of those minimize interruptions. All right, so good compressions. Number 1, push hard, push fast. 100 to 120 per minute. Number 2, compression at least 2 inches or 5 centimeters. Number 3, release completely, but don't bounce your hand on the chest. Some people now start saying they are trying to and start bouncing their hand on the chest. Number 4, compression ventilation ratio of 30 to 2. Number 5, push from shoulder. Compression ventilation ratio of 30 to 2. Number 5, push from shoulder to the heel. It is your shoulder to the heel. You're not moving from your hand. You are moving from your shoulder. It is your shoulder that is moving. So I want us to try it out. Take your dominant hand in front. Take your dominant hand. Put it here. Take your hand. Take your dominant hand in front. Take your non-dominant hand. Put it here. If you are not just looking at me, you are doing yourself. Put your hand. You're already here. There's nothing you can do again. You may as well learn. I don't want you doing like this. Put your hand. Put your non-dominant hand still. What are you doing now? I don't want you doing like this. You have missed it. This one stays still. What are you moving now? Somebody is doing like this. No, you have missed it. You are now pushing. This is how you are doing. It's your correct. This one is not moving. Perfect, man. Good. This will be life and death. Can we try that? You are pushing. This one is not moving. So this will be life and death. It must be spinal level. You cannot be thinking about it when it's happening. So you are moving like that. Good. Elbow is not moving. Elbow is not moving. It is my shoulder that is moving. Beautiful. If your hand is moving, your elbow is moving, you are wrong. So you're not moving up and down, sir. You are moving your shoulder forward like you are pushing something. Perfect. You are pushing something. But this time now you're going to push your whole body down. So I want you to watch. I want you to watch. So you can, let me bring it to the edge. So let me stand on my toes since, is there any stool here nearby? No. Okay, so here is like this. Can we all see? Shoulder should be straight, elbows locked, and then if you do it well, for every patient you do, your body will pain you. If your body no pain you, you are a killer. 2, 3, 4, 5, 6, 7, 8, 9. So I have a treadmill in my house. I do it so that you will be fit. You will not do that. You say, before they start resuscitating you too. So you do that. You continue straight. Of course, there's also adrenaline that is pumping. At that same time, you are thinking. So what I do, and if you're a senior person like prof in the house, what you try and do, I will teach that tomorrow more in ACLS. The most senior person should not be the one doing the CPR, except he's the only person. That person should be the one thinking about all the factors. This person doing well, what is next? Have we done this? What are the causative factors? Anesthesia, intubation, you should be thinking about all those things while other people are doing the work and then monitoring the rest. Okay, fine. So we'll go on to where are my slides? All right, so elbows locked, nighttime typing. Elbows locked and do not use your palm of your hand, nighttime typing, minimize interruptions. So ventilations, very important now. There are several methods of giving ventilation. One is mouth to mouth. We don't encourage that in the modern era. Another one is a bag valve mask. It's a special small thing. It's something like this. It comes in a small pouch. I've seen it, I think I saw it when I was in Dubai last. It comes in a small pouch. So you can put your mouth on it and effectively blow through it. And it has a small filter that stops anything from coming back to your mouth. So sometimes you can have that in your purse, in your car, as a small one. And this is one that we typically should have in your hospital. This is the bag valve mask resuscitator. It's also called AMBU bag, but really, AMBU is the name of a company. It's like Omo, like we call all detergent Omo. It's not AMBU bag. AMBU is the name of a company. But now then do one first, so now then get authority. So this is it. Let me see. I hope I have a slide on it. Yes, good, perfect. How many of you knew where to connect oxygen to this? Can we see where oxygen is connected? A lot of us do not connect oxygen here. So you need to get your tubing and connect oxygen right here. You will see it in every AMBU bag. If you go back now, you notice it, you will say, ah! Now, so it there before. It is there, it has always been there. Now that I've told you, you will start seeing it. So if you have the tube in your crash cart, the oxygen connecting tube is one of the components of your crash cart. We'll give you that list tomorrow on doing the ACLS. You connect it. Once you've done that, this bag will now be filled. You can see this is a reservoir bag. This reservoir bag is 2 liters. It will now be filled with 100% oxygen, so that the oxygen that the person is breathing, even if it takes in small, 100% oxygen will get to the brain to prevent brain death. The last thing you want is a vegetable to come out. So this is very, very important. Connect this part to the oxygen. Otherwise, what some of us do is that we are ventilating the patient. They are doing CPR. You just carry this in and cover the patient. What have you done? You have covered all the air. And you not connect any oxygen to it. You are the one closing the person's mouth. It's like somebody is trying to breathe and you close your mouth. And the person cannot say anything because they are unresponsive. Oh yeah? We are waiting for our turn to ventilate. 29, 30. Oh, it's our turn now, Abi. What have you done? And there was no oxygen connected before. Do you understand the ideology? Perfect. Thank you so much. Next slide or before. So one of the most important things is lifting the airway. If you not lift the airway, it will be difficult to get air in the proper direction. So we want to lift the chin up so that the airway carries the air fully in. If you don't do this, I'm sure some of you will have seen it, if you have been doing medicine long enough, what will happen is that after you've done CPR, after a while, you see the patient's tummy like this. How many people have seen it? You see the patient's tummy like this. That's because you did not lift the head up properly. So you ended up pumping the tummy. When you pump the tummy with air, what will happen? It will split the diaphragm and further stop the patient from being able to breathe. And then now, kill the patient. So wrong way of doing CPR also kills the patient. So that now splits the tummy. To make matters worse, if there was anything in the tummy, what happens next? Patient vomits. And that vomiters will now enter the airway and block the airway properly. Do you see how it happens? Okay, so how do we stop that? We raise the chin up. We raise the chin up. We want to do a CE method, and I will show you what exactly. We are virtually done. This is the last part of this one. So if there's an airway, never put your hand and do a blind finger sweep. That you're trying to clear anything that's in the airway. You need to look and suction properly. So we want to use an EC method. Now, cameraman, I need your help again. What do we mean by EC? Thank you. You want your 3 fingers like an E to be under the jaw. Is the camera showing it well? So your 3 fingers is under the jaw. Can we see it? With that, you are pulling up. Can we see that? With that, you are pulling up. You want your 2 fingers like a C to be over the mask. Now, if you look at the mask, you also notice that there's a small thing here. This thing here. Can we all see that? If you go back to your hospitals now, you will notice it was there now. You did not see it before. You are supposed to use that and use a syringe and fill here with air. Has anyone ever done that before? Never. Okay, now you know. You're supposed to use that, fill here with air so that you can see there is some air here in this one I'm holding. So that you can actually stay there and cover every space. We don't want any air to leak from anywhere around the mouth. We want all the air to go. So this is our hand. Let me use this left hand just for example. See, take it here, press it firmly. This one over the jaw, the narrow part over the nose, nasal bridge. Then, after you have pressed it, do that first. Then you now take your E and put under the jaw and pull up while still pressing. You now pull up. Do we get that? Should I go over it again? Good. So take your C, put it over the mask. Let this bigger part be on the chin. As it rests on the chin, take the smaller part, let it be on the nasal bridge. Press it down firmly so that no air escapes. Before that, make sure that you have inflated this part of the valve, of the mask. Then, take the 3 fingers after you have pressed it first. Make sure you press first. If you raise up the jaw, when you're trying to press, you will be pressing back down. And eventually, you are back to square one. So, press first. You are sure you have a good grip. Then, while you are still pressing, you want to elevate it up. Is that clear? Beautiful. It's simple, Abi? It's not very simple again, Abi? Slide, please. Mask completely. All right, so you want to now seal the mask completely. See how it did. You can see how that is properly inflated. It's around the mouth. It's properly inflated so that when you press it in, there's no air leak. Then you raise the jaw. So you now start. This is our preferred method. If you have enough people in the hospital, this is our preferred method. Somebody should just stay at the foot of the bed. This is why all hospital beds have wheels, so that you can easily move it. Somebody should stay at the foot of the bed and just hold like this. If you have enough people, if you're not alone, just hold like this throughout. Don't do anything. This is before you get an advanced airway. The 2 hands will do their 2 C's, fix it well. The 2 E's will take it up like this, and the person just stays there. That's the person's work. Typically, I'll give the laziest member of the team to do that. Or the person doesn't know how to do CPR. Oh yeah, just go and sit down there. Hold it like this. As you hold it like this, every time we give breath, the person giving breath now does not have to stress themselves about it. And oxygen is flowing. The person takes a breath, oxygen enters. When you ventilate, oxygen enters. I hope that's clear. So this one is our preferred one. If you don't have enough help and you're the only one, why not? Okay. And then the defibrillator. Defibrillator, this is a test one, but defibrillators come like this. How many of us have a defibrillator in our hospitals? Oh my God. Raise your hand well, let us see. So about 30%. Ooh. Wow. Trouble. How do you navigate this? How do you navigate this? There's no shortcut. Patients are dying unnecessarily. Hello? Let me say it as plainly as possible. Patients are dying unnecessarily. Pick up a pen and paper. Go and meet the person involved. There are hospitals that are buying CT scan today that don't have defibrillator. Talk to the person in charge. It doesn't cost much. It doesn't cost much at all. Okay? So you want to take the defibrillator, you want to get it and apply it as soon as possible. Remember, you want to minimize interruption. So CPR will continue while you're applying it. So with CPR, you will take one. Let me see. Do I have a picture? Apply it, turn it on, follow the commands. Yeah. So you take one under the right collarbone and you stick it under the right collarbone. You take the second one and you stick it under the left breast. Okay, help me. If it's a child, you put it one in front and one at the back. If you want to pace, you do the same thing. So this under the left breast and this under the where? Right collarbone. I'm saying this thing out and I'm telling you to say it. Some people are saying, some people are looking at me. Now you know I will not be there. My number will not go through. I will be sleeping. It's not that time. You say, doctor, Dr. ISEKO, yes, you taught us. Should I press now? Should I? Now you know. So take the other one under the right collarbone. Sometimes you go a little across the collarbone. So now you have set it up. A lot of times, before we do some procedures, we set this thing ahead before we start. Okay, so we set it, then we cover the patient, then we start our procedure. Anything that happens, we are ready. We just need to press. Okay, that's quite. In fact, some people do it as standard. I think in the UK it's standard. If you are doing a pacemaker, you put it first before you start. All right, so Then you now just put it on.
If the patient is a child, press the child button.
So you just follow the prompt.
In the pictures. Apply pads as shown in the pictures.
It will tell you exactly what to do.
Firmly on.
This is for people that cannot read ECG, but all of you will read ECG tomorrow. Amen, yes, join. But you will read. Yes. So you just follow it. So after you have pressed it, it will tell you when to shock. No, don't do. All right, so it will now tell you exactly what to do. What is it going to do? It's going to analyze the reading, going to tell you whether to shock or not. Okay, and then we continue like that. So when it's time to shock, everybody should clear. Nobody should touch the patient. You must shout, clear, and you must wait for a response. Everybody must shout back, clear. So that somebody is not saying, wait, let me just adjust something here. Very important. This is why you are laughing. It has happened, though. So you say clear, everybody will say clear. We have used our defibrillator in CardioCare like mad. We have used one so they don't spoil. It don't pack up. We have maybe 4 in CardioCare in one hospital. Maybe we should borrow some hospitals, Abby. No, refer patients. All right. Then you follow the prompt. We'll just move back. So I'll move back, move. When do you stop CPR? When the person starts breathing or has a spontaneous activity, you can stop. When the AED is ready to analyze the patient, you can stop. It will tell you stop CPR, analyze. When you want to shock, while it's preparing to shock, you continue CPR again. When it's shocking you, you leave. If the place becomes unsafe, you start seeing people getting ready for you. Or move. Okay, so. Can you hear me press that in? Can you hear me press that video? No. This one, can you hear me press the video? So Bernard, age 65, has ischemic heart disease and diabetes. And then you can see he's found. Bernard, help. Can I get some help, please? And then we call a code. Next, you put your head down. Listen. He's checking the pulse at the same time. Remember, you have 5 to 10 seconds. Checking the pulse and airway at the same time. And then you start your CPR and you help us come. You give your instructions. Sorry, the sound is not out there. You give your instructions and then you start your CPR. By the time you are doing this, AED has come, monitors has come, call for help, call for the consultants, extra people to do CPR, and then that's essentially what it entails. Okay? Now, every 2 minutes or so, or once you are tired, you need to exchange. So, otherwise, you will start giving poor quality CPR because you are tired. While you are doing CPR, you are attaching the pads. CPR does not stop while you are attaching the pads. So don't say stop, let me apply something. No. You can just, you can see what they did.
In a minute, I'm just going to ask you to pause and have a look at the rhythm.
This is too much.
Okay, just pause CPR. That's a shockable rhythm. Carry on CPR again. I'm going to charge the defibrillator. Can we take the oxygen away?
So,
Here.
also when you are giving the shock,
CPR.
put off the oxygen too.
Okay, stand clear.
Once the thing is ready to tell, it's ready to shock. And then, boom.
Carry on CPR.
Remember, say clear. Let the person say clear before you now continue again. So this is essentially what happens.
Bill, my name's Mandy. I'm the resuscitation team leader. What's happening?
Hello, this is Bernard. He was admitted here with chest pain and he found collapsed. He was in cardiac arrest. We've given him one shock with a defib.
So we're about a minute in.
We're about a minute in, yeah.
Okay, thank you. Right, so we've got good quality chest compressions going off 30 to 2. Isabella, our anaesthetist joined us. Can you please take over the airway management, please? Thank you. And we've got Keith.
All right. And a movie. It's time for real life. Are there any questions as we start? Are there any questions? Please don't take a passive posture in this. Ask questions. Where our people, thank you. Please come mount you will see somebody next to your table or next where there's a mannequin. If you are in front of a mannequin, just look behind. There'll be a mannequin there. If you have not left, just wait a little bit. One will come close. So once we finish with that group, we'll bring another one closer to you. Okay. Yes.
Question, sir.
Okay.
Thank you very much. My name is Ayami Fine, Medical Lab. Sir, in this cardiac arrest, can it be carried out in a accident case, like fatal accident? Maybe the guest has some injury. Can that be carried out?
So it does not matter what happened. You want to do your CPR. You want to try. Whether it was from accident, heart attack, cancer, whatsoever. There are some times that doing CPR may be futile. The person has been suffering for 3 months just there, you know, and they've told you, please do not resuscitate. That's a different matter. But it does not matter what caused the cardiac arrest. Once somebody is having a cardiac arrest, you are duty bound to give appropriate care. Please don't make too much noise. Just find where you are going, and then we'll start. We'll take a few questions, and then we'll start straight away.
Sir, thank you for this presentation. My name is Dr. Rukaya. Sir, please, is it the same approach you demonstrated here that we're going to do for a patient's gasping?
Okay, so what did we say about gasping? We said it's a respiratory arrest, right? Meaning that there's a pulse, but there's no breathing, right? Or the breathing is not good. What did we say we're going to do for that one? Rescue breaths only. So for a patient gasping, what you are going to do is that you will not start compressions. All you will do is that you will start just this one. Get the airway in and start calling for help so that you can start advanced airway. You want to intubate the patient as soon as possible. So call for help. I think I'll take one final question and then we'll take the questions on the tables. Please, you cannot learn by watching. Some of you think you have learned. You have not learned anything. You cannot learn by watching. You're already here. Just take the next 10-15 minutes. Do the CPR process on the mannequin. Let somebody correct you or direct you. If you are doing it wrong, take corrections very seriously. Because the next time you'll be doing it, I will not be there. Somebody will be there. You will be on your own.
Thank you, sir, for the elaborate information. I want to find out at what point do you inflate the face mask? Is it at the point of making the chin grip, or is it before you apply the face mask that you're going to inflate the face mask? And then the second question I want to find out is, I've been in a situation where there's actually no oxygen and we have to use the ambu bag. So is it that we shouldn't apply ambu bag if we don't have oxygen?
You can apply the ambu bag if you don't have oxygen, but don't leave the ambu bag on the patient's face since there's no oxygen. Take the ambu bag while you are waiting for your time, and then let the patient get some air that has 21%. Then you can put it on and off. But at all, 9 bad pass. So now for the ambu bag preparation of the face and the valve mask, you should have prepared that before the thing started. As you're starting your shift, your work, make sure that all those things are prepared. We've seen patients that collapsed or had cardiac arrest while doing a CT scan in the diagnostic center and nobody knew what to do. They are now calling, you have a patient, there's nothing that can. So you need to know what to do. So before you start, you should have made sure that that bag was properly done, checked. Before you do, you will check it every shift. 2 times a day we check it in all our hospitals. Every crash card they check is working, check is working, check oxygen is working, check the defibrillator is working. You must do that at every shift because you never know when it will be. Prof, sir.
Good evening all. My name is Aminu Muhammad Balarabe. I just want to shed a little more light on the question on trauma patients. Multiply injured patients suspected to have cervical injury, you have to be extra careful during the airway management. Don't do the chin lift, head tilt for patients with suspected cervical injury. If you do that, you make an incomplete cervical injury complete, and you will end up losing the patient. In that situation, you do what we call the jaw thrust, which means you have to use your 2 hands and elevate the angle of the jaw at the same time. I'm sure, yes, will be demonstrated. Can you make a comment on the use of an oropharyngeal airway? at this stage of the resuscitation. Thank you very much.
We're going to use airways. We're going to do airway tomorrow, actually. Oropharyngeal, laryngeal mask. But in this stage, sometimes oropharyngeal airway is actually good. If you can, I don't have anyone here to demonstrate, but it's good. It can help keep the tongue from falling back. It can help while you are doing your bag mask that the tongue does not fall back and you are not doing your bag valve mask against a closed airway. So it's very, very important. If you have an oropharyngeal airway, apply an airway. Yes, if there's a cervical fracture, please, you don't carry it like this. You take it from the jaw and you do it in a particular way. I think I have a slide on it. Thank you very much, sir.